Hi everyone, thanks for coming. My name is Petty, I'm one of the 3Bs, and I'm going to be taking you through pharmacology. So I'm a postgrad, so I didn't have your end of year exam, but we would have had the same VIA. On our VIA we had about 7 marks dedicated to pharmacology, and a lot of it is, some of them were quite random question types. We'll try to go through some of them. I haven't put any questions in here just because I didn't have access to your papers, given that I came through slightly differently. But I'll try to go through the question styles that we had. If you have any questions, let me know. I'll stop and I'll try to explain things. I can't promise I can explain everything, but I can try. And I've changed the order of the slides based on what you guys said you wanted presented first. So as we go through, you guys might have to like Control F and like find where we're up to, because it's not going to be in order on your presentation. So these are my references. So just quickly, I just put in a little bit about the receptor subtypes. This is more important for obviously your RESP and your cardio drugs, and not as important for other things. Sorry? I don't know, whatever you guys can read. I'm reading it off here, so it doesn't... Alright, cool. So I'll start off with some endocrine drugs. At the start of each of the sections, I've put a little bit of basic physiology. This is obviously not what you need to know for your exams, but it's purely just to get you in the mindset. You guys need to know physiology really well in order to understand pharmacology. So a lot of people say that pharmacy and pharmacology are really difficult to learn because everything's kind of like abstract and whatnot, but it's really not. Everything is purely based on physiology. So once you understand the physiology of all the different conditions, you can deduce, without knowing what drugs are out there or anything, how you might treat the condition, what the drug might look like, and what its side effects might look like. So if you're ever stuck, don't rote learn. Personally, for me, rote learning doesn't really work. I need to understand concepts. And if you understand pharmacology, it'll make sense. But in order to do that, you need to have a good understanding of your physiology as well. And so these lectures should really help you out with all your physiology, obviously. So in terms of thyroid, basic physiology, I'll mostly gloss over all of these. So obviously the action of a thyroid hormone is to increase your basic metabolic rate, okay, and you can have either a hyper or a hypothyroidism. The synthesis of the hormones is more important for your physiology exam, not really for pharmacology, because there's not that, the drugs don't, it's kind of like a one-liner in terms of what they do, so you don't really need to know it in depth for pharm. But it's good to know a comparison of T4 against T3. Now, I haven't really put in any like animations or shit or anything to make you guys like try and guess stuff, but obviously try and do this by yourself when you're revising. So T4 is the main drug that we use, the main drug target, and there's a larger pool of it in our body. So we have around about 1 month's store of thyroid hormone in our body at any one time. And that has implications for when we treat someone, because it means that when you start treatment, you're not really going to see an effect immediately, unless you are able to essentially decimate that entire 1 month supply. It's got a much longer half-life, which once again has a lot of follow-on effects in terms of if you screw someone's thyroid, they could have troubles for quite a long time. It's not something that is out of the body that quickly. However, it's less potent. So T3 is your main active form of thyroid, and it is what causes all the effects in the body. T4 is kind of just like a vehicle which later on becomes active when it gets peripherally converted. So this is like the only animation I've put in my slide. So can someone tell me, in primary hyperthyroidism, what happens to the TSH? Low, yeah. And so what would be T3 and T4? High, yeah. So there you go. That's it. So you guys obviously already know this really well, but it's really good to get into a habit of knowing the primary, the secondary, and even the tertiary causes, the changes that happen in endocrine diseases. So to treat hyperthyroidism, you've got your thionamides. which are the primary method of, oh, look at this. So they're the primary method of treatment, okay? Beta blockers are good for your symptomatic treatment of the patients, especially prior to giving them surgery or prior to giving them other treatments, or in the acute setting where they're really having trouble with the symptoms, but you're waiting for the other drugs to kick in. Iodine and radioactive iodine obviously don't really come under pharmacology, so I won't really cover them much. And then surgery is your definitive treatment for a lot of these thyroid conditions. So hyperthyroidism, your thionamides, or your carbimazole and propylthiouracil, they're inhibiting the iodination of the thyroglobulin. So you're not able to produce T3 and T4 anymore. However, like we've said, they take a long time to work. And so in the time that you're waiting for them to work, then you need to be giving them symptomatic treatment, such as with a beta blocker. PTU works a little bit better in that it reduces your peripheral conversion. So PTU is actually working at two separate stages of the process. Both of them are category C drugs, which means they're not ideal in pregnancy. However, what do you guys know about hyperthyroidism? Who usually gets hyperthyroidism? Females of around about what age? Of childbearing age, right? Yeah, so you can't really avoid it, and although it's quite commonly used, it's still a category C drug. We use PTE in the first semester because it has more evidence in the first semester, but after that point, you switch back to carbimazole. In terms of the in terms of the ADRs, your rash and headache are probably your two most common, but the most important is agranulocytosis. So do you guys know what agranulocytosis is? Can someone explain it to me? Edward, can you explain it to me? I only know like 2 people in this lecture theatre. No? That's a good way of getting out of it. So it's essentially really, really low white blood cells. So you get a leukopenia, right? And if you have low white blood cells, what's that going to mean for you? Immunosuppression, yeah. So you can get opportunistic infections, and even normal infections will be of a much larger consequence for you. So it's really, really important that when patients take these drugs, you tell them to look out for signs of immunosuppression. Do people know what the signs of immunosuppression are for like a lay person? Obviously, if you get an infection, you're going to come in, but oftentimes a patient might not know that they've necessarily got an infection. So what might be 1 or 2 signs that you would be looking for? What might you find on their vitals? Yeah, tachycardia. Often patients might not know that they're tachycardic unless they have palpitations, right? So they might know that they have palpitations, but it's going to be a bit difficult to differentiate the palpitations from agranulocytosis causing infection and just their hyperthyroidism, because a hyperthyroid patient is going to be tachycardic. So the ones that you're looking out for are things like fever, yeah, a sore throat, a rash, or mouth ulcers. Mouth ulcers is a big one. Not many people get mouth ulcers, right? And it's not like one mouth ulcer where you might like say, oh, the patient might have herpes or something like that. Or if they've been just acutely unwell, they've been stressed lately and they just get a mouth ulcer. These patients might have like lots of little mouth ulcers. So yeah, so you need to be looking out for that one. And there's 2 ways that you can give them these drugs. You can either go for an adjusted regimen or a block replace. So depending on how you treat their hyperthyroidism, an adjusted regimen means that you give them the drug, you wait, say, 6 months, or like 4 weeks, 6 weeks, 8 weeks. Wait a period of time, you check their TFTs again, and then if they're still high, then you give them more. You check their vitals, if they're still tachycardic, you give them more, right? Or the block replace is where you actually give them thyroid blocking drugs and essentially obliterate the thyroid function of the thyroid, and you give them replacement exogenous thyroxine. But oftentimes, these patients who have hypothyroidism might get their thyroid out. So if they've got absolutely no thyroid to go off, then you're obviously going to give them high thyroxine to go with. Beta blockers, like we said, it's only for symptomatic relief and only really for tachycardia and maybe the tremor and the agitation. So a lot of people use beta blockers for things like stage fright, because stage fright gives you similar sorts of symptoms, right? So when you get up on stage and you're about to do a talk, you might be tachycardic, you might be anxious. So always consider using beta blockers with these kinds of symptoms. Yeah. Beta blockers also reduce the vascularity of the thyroid gland, and why might that be important? Yeah, so in surgery it's going to be a lot better because it means there's less of a risk of sequelae from the surgery. Hypothyroidism is much easier to treat because all you're doing is replacing what's lost. And when you're thinking about the side effects of thyroxine, all you really need to think about is what happens when you're hyperthyroid. Yeah? So really easy. Liothyronine, which is T3, is very rarely used, and it's only used in endocrinological emergencies such as myxedema coma, where the thyroid is so low that you have to replace it really quickly. Like we said before, T4 is less potent, but it hangs around longer. So you don't really want to wait 4 weeks for the maximum effect of thyroid to kick in. You want something that's going to be used up right then and there. Like I've written here, the maximum effect of thyroxine is seen in about 10 days, but a single dose can last for about 3 weeks. So it's really important to note that down when you're treating someone. Alright, so diabetics. Obviously, insulin is the hormone of the fed state, so when you eat, insulin's released. Try to get that glucose into the liver and build up your glycogen stores. Glucagon is released when your blood sugar is low, and you try to push out as much glycogen, convert it into glucose, put it into the bloodstream for use. Type 1 diabetes, you've got destruction of pancreatic beta cells, so you physically do not have insulin to provide. Type 2 is you have the insulin, but because of the way that your body works and the resistance to the insulin is not enough in order to control your blood sugar. And that has implications because it means one group has to go straight onto insulin and the other group has got other options before they go onto insulin. So the complications of diabetes, obviously the biggest presentation of a type 1 diabetic, the first presentation is almost always like a DKA, or they'll come in with polyuria, polydipsia. Yeah? In terms of chronic, you've got to think about your micro and macrovascular. Drugs can help you with microvascular complications, but they can't help you with macrovascular complications. So once you have diabetes, you are at increased risk of things like peripheral vascular disease and cerebrovascular disease like strokes, and you can't do anything about that. No matter how well you control your blood sugars, you will be at a higher risk compared to someone who doesn't have diabetes. But if you control your diabetes really well, you can reduce your risk of getting your microvascular. Obviously, diabetes is a chronic condition, and it's something that means that at some point in your life, you'll probably slip up, and you probably won't be controlling it that well. So patients are going to get these things. But it's just a matter of time. Insulin is used in your type 1 diabetics and in your late stage type 2, and there's a few different regimens of how to do it. You've got your basal bolus and your split mixed. Those are the two most common. Basal bolus more so resembles an endogenous release of insulin, and so it's used for type 1 diabetics, where they have absolutely no insulin to go off. And what that consists of is you give them a really long-acting peakless insulin, and that's usually given at nighttime. And then on top of that, when they have meals, you give them short-acting or ultra-short-acting to cover them for the extra carbohydrates that they have in that meal. Split mixed is usually a twice-daily regimen where they take a pre-mixed insulin, and so I've got down here 30, 70, and 50-50, and so that's the mix between short and long-acting. And this is only for type 2 diabetics, so you'd not give something like this to a type 1 diabetic because it doesn't accurately mimic what the body should be doing. Then you've got the people who've got like continuous infusions via insulin pumps. They're really expensive, so you don't really see that often. So this is one of the tables that we got last year. I'm not sure if you guys had this table, but you can find similar tables, or you can just use it off the slides. So we had a A good exam question to ask might be, this patient's come in with this particular symptoms. You've decided to give him insulin. How long is this insulin going to act for? When's it going to peak? What's it going to be like in the body, right? So it might not be a bad idea to have look at these numbers and try to commit some of them to memory. But obviously these numbers are going to be quite varied depending on each table you look at. What I would kind of go for is look at the ones that are ultra short acting and realize that they act almost immediately. So the ones that are ultra short acting, they don't form any kind of hexamer or polymer, or don't associate with anything in the body. They go straight into the blood, right? Straight from subcut into blood, and therefore they work immediately. Ultra short acting is the only type of insulin that you can give while you're eating. Yeah? Everything else you should be giving before you eat, in terms of the ones that are used during the day. So short acting, as you can see, it can take up to an hour for it to actually kick in. And so you want to give this at least 15 minutes to half an hour before your meal. What this means for the patient is that they need to know what they're going to eat, because they need to titrate their dose. So if, for example, they give themselves, they think they're eating a particular meal, and they give themselves, let's say, like 6 units of short-acting insulin, and then after they've finished that meal, someone brings out garlic bread, and they love garlic bread, and they want to eat it. The ideal situation would be that they would inject themselves with more insulin, then they would wait. However, the ultra-short acting, they can just inject themselves again and give themselves a few more units to cover them for the extra meal. Intermediate acting isn't really used that commonly for patients who, for type 1 diabetics, because its profile isn't as nice and doesn't conform as well to the whole basal bolus regimen. Your long acting, so these are peakless insulins. So these cannot be used pre-meal. These are only used to give you a basal level of insulin release throughout the day. Okay? And they're used usually at nighttime. The difference between them, what makes one long-acting and one short-acting? Glycogen and detamine, one of them forms a hexamer, so it becomes into this big molecule which needs to be broken down by the body, and so it takes a while for it to be broken down. And the other one binds with albumin, and therefore it takes a while for it to dissociate. The intermediate and the short-acting ones, they can form polymers, so they once again need to be broken down before they're utilized properly. These are things that you need to know as a year 2, but once you get into year 3, no one really ever asks you about them again. So the oral hypoglycemics, you're probably more likely to get questions on these in your exam. Insulin, you might get one question on it, and it's probably going to be something similar to this. But your oral hypoglycemics, you might get other questions on it. So sulfonylureas, these are one of your first-line drugs for a type 2 diabetic. One of your first-line drugs. You've got the names of all of them here. A cool little trick is the longer the name is, the longer its half-life is. What kind of implication do you think that has for a patient, how long the half-life of this drug is? Anyone but the lady down in the front. Yeah, and yes. It's a great input. So what's that going to do for the patient? What does that mean?
It means they don't need to take as many drugs.
Yeah, so it sounds good in theory, right? Because it means you don't need to take it for as much. But these drugs are what's called insulin secretagogues. So they actually act on the pancreatic beta cells and force them to release more insulin. Because remember, in a type 2 diabetic, the beta cells are there. They just aren't sending out enough insulin for it to be useful. So these drugs come in and force more insulin out. But because they're longer, because they secrete insulin, insulin can cause you to go into a hypoglycemia, right? If you give out too much, you're going to give hypoglycemia. And when you take the drug doesn't know, oh, you've just eaten this amount of carbs, I should only act to 75% of my potential, and therefore to prevent you from going into hypo. Something like a glibenclamide is going to act for so long that you might go into a hypo eventually. So they're really bad in elderly people who are at risk of falls. Someone who's young can understand that they are going into a hypo, and therefore they can give themselves, take more sugar in and counteract the effects. So typically you're not going to see things that are long-acting used. Hypoglycemia is the biggest side effect they need to be aware of for these ones. The way you should think about the side effects for a sulfonylurea is not to consider the sulfonylurea itself, but to consider insulin. Because they're releasing insulin, what you can do is you can bunch the adverse effects of insulin with sulfonylureas, and that's one less thing to think about. So insulin is going to cause hypoglycemia. It's going to cause increased appetite and weight gain. Weight gain is probably the other big one. They can also cause skin reactions and blood disorders, but you're not really going to be asked about this. So the two big ones are probably hypoglycemia and weight gain. They've got hepatic metabolism and they bind to plasma protein, so if you've got a patient who's got liver dysfunction, then they may not be the best drug to go with. Biguanides, or more commonly, there's only one drug in this drug class, and that's metformin. Monash loves asking you what a first-line drug for a particular patient might be. So sulfonylureas and metformin are probably your two big first-line drugs. In what situation would you use a metformin over a sulfonylurea? Overweight? Yeah. Have I written that down? Yeah, okay. So if the patient is overweight, then it's a really good drug to start. And often it might be, for example, the patients come in, they've got type 2 diabetes, they're overweight, which go hand in hand. What's your first-line drug? So in these patients, you wouldn't give them a sulfonylurea because that can cause them to gain more weight. Metformin itself doesn't actually do anything with insulin. Therefore, it's not going to cause weight gain, and it's not going to cause hypoglycemia. All it does is it makes the body more efficient at what it should be doing normally. So it's decreasing its gluconeogenesis, so you're not creating as much glucose anymore. It increases the uptake, so your sugar is pulled from your blood and into the liver. It slows the absorption of the glucose, and it stimulates tissue glycolysis and fatty acid oxidation, which is kind of like how it helps you to lose weight. So it's a really, really good drug because it's euglycemic. Patients are going to have hypos, and they're going to lose weight. The thiazolidinediones, these are not used very often anymore, mostly because of the effect that they have on the heart, and they can worsen or induce heart failure. So they're PPAR gamma agonists, and they mimic the insulin action, but they do so by causing the cellular changes that insulin normally would without the need for insulin. So they go into the cell and work at a nuclear level to cause gene changes, gene transcription changes. So they improve the sensitivity of insulin. In terms of the side effects, they can cause fluid retention practically everywhere. So like peripheral edema, pulmonary edema, facial edema. They're not very commonly used, but if your patient has got any kind of heart trouble, this is the drug that you should not prescribe. This drug you guys don't really get taught, I don't think, but basically acarbose, what it does is it slows the breakdown of your polysaccharides and your disaccharides in your meals. And it helps to slow the digestion and gives the body time to deal with the sugar that's coming in. So you only really take it when you're eating meals. If you're not having a meal, then there's no point in taking it because it's going to have no action. Any oral drug can always cause oral side effects in terms of your stomach, so like GI upset and whatnot. This particular one is obviously helping things break down, but also kind of stopping them. So it's going to cause things like flatulence and diarrhea and abdominal discomfort. And it's not very commonly used mostly because of the flatulence. Patients don't want to be farting the whole day, especially after a meal. The consideration with this one is that because it stops the breakdown of your disaccharides, if you go into a hypo for whatever reason, this is not a first-line drug. So a patient who's on this is likely to be on metformin and a sulfonylurea before this, and they are at risk of a hypoglycemia. But if they take this and you give them like a sandwich or something, it's not going to work. You need to give them pure glucose because everything else is going to be slowed down by this. Or the alternative is that if they haven't taken their A-carbose prior to having the hypo, then you should be okay. So incretins cover two different types of drugs, your DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors, and your GLP-1 analogs, your glucagon-like peptide analogs. And they both work to do the same thing, but in slightly different ways. So incretins are endogenous hormones that increase your insulin sensitivity, stimulate the release of insulin, reduce the glucose, and everything I've written here. One of the drugs, the DPP4 inhibitors, inhibits their breakdown, and the other one acts as an exogenous like hormone and does the same effects. So the GLP-1 analogs, or the exenatide is the most commonly used one, acts as exogenous incretin. These are injected drugs. So this is the only other diabetes drug aside from insulin that needs to be injected. And its biggest consideration is pancreatitis. So if they get abdominal pain while they're on this medication, then they should be stopping. DPP4 inhibitors, these are increasingly becoming popular, and these can sometimes be used as first-line drugs, especially if, for example, they're worried about sulfonylureas and their renal function is really off. But they're not as effective as the other drugs. And I've got a little table at the end of this which shows you the effectiveness of all the different drugs. So once again, they cause similar kinds of side effects. Your SGCT2 inhibitors, these are the newest kids on the block, and they prevent glucose from being reabsorbed in the kidneys. So all you end up doing is you end up pissing out all of your glucose. Because you've got glucose in where glucose usually isn't, in your urethra, in your bladder, and things like that, they increase your risk of infections, urogenital infections, without giving you that much of a decrease in your HbA1c. One of the biggest considerations for this is that their urine will test positive for glucose. And obviously that's a bad thing for a diabetic, right? Because if usually if their urine tests positive for glucose, it could be a sign of renal problems. But in this patient, that test becomes less sensitive and specific. So this is your comparison. So insulin and your biguanides are going to give you the best reduction, followed by sulfonylureas, and then the rest. Any questions so far? Is this too slow? Or is it too quick? Okay. All right, so in terms of your bones, so blasts create bone cells, clasts do bone resorption, and they have rank receptors, which are a target for therapy. And your osteocyte is just a trapped osteoblast, which helps to regulate their activity. Parathyroid hormone works to increase your serum calcium by indirectly increasing osteoclast activity, so breaking down more bone and releasing the calcium from within the bone into the bloodstream. Calcitonin opposes parathyroid hormone. And vitamin D, or cholecalciferol, increases your mineralization of bone and increases your calcium uptake. That's just basic physiology. So D3 is the most commonly used form of vitamin D, and it's the one that's available as an oral capsule or tablet. And the main reason we use it is that it increases your absorption of calcium from the GIT and phosphate from the kidneys. It itself, a fat-dependent vitamin, doesn't cause any side effects or anything. The side effects purely stem from a hypercalcemia point of view, which is like your stones, bones, groans, moans thing. Have you guys heard of that? Yeah? Cool. Because it's a fatty molecule and it's stored within the fat cells of your body, it can be really difficult to get rid of it. So it's quite difficult to get your levels up, but once they're up, it's quite difficult to get rid of it. So you need to take that into consideration. So someone who's overdosed on a vitamin D, it's going to be quite difficult to get that out. But overall, it's quite a safe drug, and even if the patient's levels of vitamin D are quite high, you can generally just stop it, and then they shouldn't really have any follow-on effects. Calcium itself can either be used for hypocalcemia or as a phosphate binder. So calcium is a heavy metal drug, and when taken orally, it's going to bind to certain drugs and certain foods, and certain molecules, obviously. So the molecule that it's going to bind to is phosphate. Who has high phosphate? Which group of patients? So people with renal failure have quite high phosphate. So they might be on something like this. They hate taking the drug because it tastes like chalk, and it causes them to have constipation, flatulence, abdominal discomfort, but it's used for that kind of thing. Bisphosphonates are the ones that most of your questions will probably be surrounding. And the two most common ones are alendronate and risedronate, and they're most commonly used for osteoporosis. So they're inhibiting osteoclasts and inhibiting their activation, therefore decreasing bone resorption. What this means is that your bone mineral density is going to be preserved, and so you're not going to become osteoporotic. Because they're working on the bone, you can kind of think about how they might cause, if they're causing changes in bone, then they're going to cause bony type of pain. These drugs, as well as a doxycycline, can cause esophagitis and esophageal ulceration and erosion. So these tablets, the way you explain it to patients is that they get stuck in the back of the throat. And anything that gets stuck can cause like ulceration and pain and inflammation. So they need to take this drug, they need to be sitting upright for at least half an hour to an hour. After having it, take it with a full glass of water. Yeah? They've actually been shown to be associated with stress fractures and some other problems, but that's not really important for your exams. The other thing they can be used for is hypercalcemia of malignancy. So as you can see, one of the main side effects of bisphosphonates is hypocalcemia, and we use that therapeutically. So if you give these drugs in much higher doses, then you can use them to reduce the calcium in your body. They're only really used for patients with cancer. Calcitonin, so we already talked about how this directly opposes PTH action, thereby increasing your calcium uptake by bone. Once again, you probably won't really see it in your exams, so you can kind of go through this in your own time. Teriparatide, probably don't really need to know it. But one of the biggest things is that you can't use this for very long because the risk of osteosarcoma, so cancer of the bone, increases dramatically after about 18 months. Also, another thing to note is when you've got hormones in the body, if you give that hormone exogenously really frequently, then it can sometimes cause suppression of that hormone, and you actually get the opposite effect to what the hormone usually does. And that can be used therapeutically in, for example, someone who's got a prostate cancer. And so you give a gonadotrophin really frequently, and that suppresses everything, and that works well. Similarly, teriparatide is a peptide fragment of PTH, but it's actually doing something different to what PTH does. So it's a little bit confusing in how they work, but you don't really need to know much about it. Cinacalcet's only really used for hyperparathyroidism, and all it does is it reduces your parathyroid release. Parathyroid usually increases your serum calcium, so obviously the biggest side effect of this drug is that it's going to cause hypocalcemia. Hypocalcemia is going to cause paresthesias, myalgias, and weakness. There are occasionally questions on how a patient's comorbidities might affect drug absorption or drug effect. So for example, if someone's liver isn't working, then their liver enzymes aren't going to be working. They're not going to be breaking down the drug that you're giving them. Therefore, your side effects are going to be increased. Right? So you guys should think about which drugs are either extensively cleared by the kidneys, extensively metabolized by the liver, or extensively protein bound. Those three categories, if anything fluctuates with them, then you can get a vast increase in your drug action. The biggest example that I can give is something like phenytoin. So phenytoin is like 99% bound to plasma protein, right? So that means that of your 100, let's say you give the patient 100 milligrams, and 99 milligrams is bound to plasma protein, and 1% is in the blood. If their plasma protein goes down by 1, so now they have 98 plasma proteins, you've effectively doubled the dose of phenytoin in their blood. Yeah? So even though they've barely changed in their physiological state, the amount of drug available to act is now double, and therefore it's going to cause double the effects. So it's really important to consider. So you guys should know about your anterior and posterior pituitary. This stuff I'm probably not going to go through just because you're not really going to get anything on it, and you can just read it in your own time. Unless you guys want me to go through it. Say stop if you want me to go through something. Okay. Alright, so you guys can look at that. So non-steroidal anti-inflammatory drugs, these are one of the most commonly used pain relief medications. You've got COX-1 and COX-2 inhibitors. Some of them are purely COX-2 inhibitors, and some of them are non-specific inhibitors of COX. COX-1 is what we require in order for normal physiological function. COX-2 is the one that's dubbed the bad one because of it's got the most pro-inflammatory effects. Now, Monash kind of wants you to believe that something that's a COX-2 inhibitor isn't really going to have the same problems as something that's non-specific, and that's not really true. They both have very similar side effects. So in terms of, for the patient, it's not really going to make too much of a difference, but for your exams, something that's COX-2 is obviously going to be better to use than something that's non-specific. The biggest side effects are GI upset and ulceration, especially when in conjunction with things like smoking and alcohol. Bleeding. So these drugs can thin the blood in a sense, and so bleeding's a bit of a problem. They're not good in people with hypertension because they can cause sodium and fluid retention, therefore increasing your intravascular volume and increasing the amount that your heart has to do. So they can worsen things like heart failure. They can also cause renal dysfunction. And have people heard of the triple whammy effect? Yeah, so that's when you use an ACE inhibitor, which dilates your efferent arteriole. You use an NSAID, which constricts your afferent arteriole. And you use a diuretic, which depletes you intravascularly, and that causes renal failure. Now, in real life, that combination is used frequently, but the patient is monitored. For exams, that combination is never to be used because the patient will die. Anti-inflammatory drugs aren't recommended long-term for anyone because of the effects that they have, but if they've got anything along this, so if they've got a cardiovascular history, then they're recommended even less. So steroids increase the production of annexin-1. Prednisolone is the most commonly used steroid. Hydrocortisone and dexamethasone are less commonly used. Dexamethasone is used in a lot of... Dexamethasone actually doubles as an anti-nausea medication and is used in a lot of cancers to reduce inflammation. Prednisolone is used in a lot of autoimmune type diseases and also things like infective exacerbation of COPD or childhood asthma and things like that. Hydrocortisone is kind of in that middle zone where it's not really used much at all. Because they are affecting your genes and gene expression, protein expression, they take time for full effect. But oftentimes, people actually do see an anti-inflammatory effect quite quickly, but it can take quite a while for their full effect to kick in. Their side effects are something that you need to know and will be asked frequently, if not in this exam, in next year's clinical years or in other exams. So they affect the whole body, and I'm sure you guys, I don't think I've put a picture in here, but I'm sure you guys have seen those pictures of a person with like all of the different side effects, yeah? If you haven't, you can Google it and that might help you to remember. Mood changes, these occur with a higher dose or longer term use of the medication. The most acute side effects that you're going to get are stomach upset, GI upset, and sleep disturbances. So to counteract that, you tell a patient to take the medication in the morning and with food, and that helps to stop those from happening. But things such as mood changes, thin skin, delayed wound healing, hyperglycemia, osteoporosis, all of those can't really be mediated in any way and require monitoring. The big ones are hyperglycemia. So if a patient's been on steroids for a long time, then they can become a diabetic patient. Osteoporosis, a lot of these people will have atypical type fractures that people of their age shouldn't really have. They get the truncal obesity with a purple striae. Purple striae is like a buzzword for steroid use. And the immunosuppression and adrenal suppression. So if someone's been on a relatively high dose of steroids or a medium dose of steroids for about 2 weeks or longer, you do not stop the steroids suddenly because they will go into an Addisonian crisis. Because what happens is you get suppression of your normal endogenous steroids because the body just sees that it's getting steroids from elsewhere and doesn't want to create more. Your DMARDs, there's no really good way to remember your DMARDs, and I can't really teach you a really good way to remember your DMARDs. They're not really going to be quizzed, just because each one has got its own mechanism of action, and each one's got its own side effects and its own considerations. The one that you should remember, which you'll be quizzed on the most, is methotrexate. All the others, you can remember if you have time, but I'm sure you're going to get more high yield out of learning something else. So methotrexate is a folic acid antagonist, and it's inhibiting DNA synthesis, and it's used for a variety of different conditions. The two biggest ones are either autoimmune disease like RA or various cancers. Its ADRs and its considerations are quite long. So methotrexate can affect the whole body. Obviously, if it's used for cancers and autoimmune conditions, it can reduce your immune system, so you're going to get myelosuppression and immunosuppression, so you're going to be at increased risk of infections again. It's cleared by the liver, but it also affects the kidney, and if your kidney function is reduced, then your levels of methotrexate can go up. It can cause photosensitivity and neurotoxicity, and really bad skin reactions, so things like Stevens-Johnson syndrome. The dosing is once a week for autoimmune, but it's usually a daily dose for your cancer. But if you know how it works, which is a folic acid antagonist, and maybe the fact that it's not good for your liver, kidneys, causes myelosuppression and pulmonary toxicity, that's probably all you would need to know. Alright, so any questions so far? Alright. So psychosis. Schizophrenia is a mix of positive and negative symptoms. Your positive symptoms are due to overactivity of dopamine, but your negative symptoms are due to underactivity of dopamine. Now this creates a bit of a problem because initially you couldn't really give a drug that both inhibited dopamine and increased its actions. So what would happen is if you gave one drug, it would cause an exacerbation of the other symptoms. Nowadays we have, you can read that by yourself. Nowadays we have drugs that are partial agonists, or agonists at one place and antagonists at another. Our first generation antipsychotics, or your normal or typical antipsychotics, these are the really old school ones. So they are antagonists at all these different receptors. Based on the receptors that they act at, you're going to get different side effects, and I've written them here. So dopamine, what's the other disease that the pathophys has a lot to do with dopamine? Parkinson's, yeah. So if you're screwing around with your dopamine, you're going to get movement disorders. And so with these drugs, the biggest consideration is EPSE, extrapyramidal side effects. We'll go through them in a bit. Other than that, acting at H1, you're going to cause sedation and maybe a little bit of weight gain. Acting at your muscarinics, you're going to get anticholinergics. Have you guys heard of SLUD? Yeah, so you're going to get your anti-SLUD type side effects. Yeah? Working at your autonomic, you're going to get postural hypotension, so they're going to be quite dizzy. Then you're going to get weight gain from your serotonin receptors. These treat your positive symptoms and not your negative symptoms. Do you guys know what positive and negative symptoms are, what the differences are? So positive symptoms are anything that's additive, so like hallucinations. Negative symptoms are like not participating in society. Actually.
Okay, what's the PFC?
In prefrontal cortex. So EPSC is your biggest concern, and these are the different types of EPSC. Tardive dyskinesia is the one that you don't want because it's irreversible and can occur at any point in time if you've had antipsychotics. So they might be off antipsychotics, then like 2 years down the track, they get uncontrollable movements of their tongue or face or lips, and that's permanent. Dystonia is probably the more common ones, dystonia and akathisia, and they can be not permanent. Forgot the word for not permanent. Temporary. They can be temporary. Second generation antipsychotics are the ones that are most commonly used now. Their biggest, so they have a varied varied mode of action. Some of them are partial agonists, some of them are antagonists at D2 and 5-HT2A. These are much better at treating your negative symptoms. The biggest concern is metabolic side effects. So these people that take these medications get weight gain, and they, as a result, they can get diabetes from it. So those are your two biggest concerns. These three are the biggest culprits, and they can actually cause like a weight gain of maybe 30 kilos. So these patients can become quite fat. And that's a big concern for the patient, because these patients already have a mental condition. They're already stigmatized in the community. And then after getting on these drugs, they suddenly gain 30 kilos. They've got all these other health problems. They have trouble accessing healthcare. This isn't to do with your exam, but I think it's just like quite interesting. Clozapine you need to consider, because clozapine can cause agranulocytosis as well. And so patients on clozapine need regular monitoring of their neutrophils. And it's actually a traffic light system. So depending on what the neutrophils are, you might either stop the medication or give them a lower dose. This is your comparison of your adverse effects of some of the antipsychotics, and there's pluses and minuses everywhere. But if you remember that your atypicals cause metabolic side effects, and clozapine can cause agranulocytosis, and your first gen causes movement disorders, that's probably enough. Okay, so anxiety is just a perception of imminent threat or harm. And you can give them preventative treatment. You guys probably don't need to know much about anxiety besides benzodiazepines. So benzodiazepines enhance the effect of GABA. Without GABA there, a benzodiazepine is not going to work. So if they, for whatever reason, they have like reduced GABA, this wouldn't be a clinical case. This might be like a pharmacology type question. If their GABA is not there, then you're not going to, the benzodiazepine is not going to work. GABA is your inhibitory neurohormone in your body, so it's going to cause symptoms of everything slowing down. So sedation, amnesia, you can get like a hangover effect. And they're quite problematic because of the tolerance and dependence. So people become tolerant to one dose, require more doses. As they take more, once you stop taking it, they find they can't get to bed, they find they're agitated and things like that, and therefore they become dependent. Then once they stop, they start to withdraw, and they can get things like seizures. Right, so epilepsy is the uncontrolled electrical discharge in one or more areas, and it usually starts in the cortex, then spreads. Epilepsy in itself is multiple seizures. So if you've had one seizure, you don't have epilepsy, you've had a seizure. There's a few different ways to treat seizures. You can either increase the dampening hormone, which is GABA, or you can decrease your excitatory stuff, which is usually sodium. And that's basically how all of the drugs work. So as you can see, valproate works on almost every single one of these methods. So valproate and carbamazepine as well. So those two are your two big first-line drugs for almost all types of seizures, with the exception being your absence seizures, which you use ethosuximide. So the side effects are once again really quite varied, and you probably don't need to know a lot of them, but I've put them in here just for reference. They can all cause sedation, confusion, mental state changes. They're screwing with your brain and how your brain works, therefore they're going to cause lots of CNS type side effects. Common ADRs are skin reactions, and they can be quite severe skin reactions, and vision changes. They're generally not good for pregnant ladies, but if a pregnant lady has a seizure, that's going to be pretty bad. So they often keep them on an anti-epileptic. And usually, you try to go for one anti-epileptic and not multiple. Multiple does not mean better in this sense. So have you guys heard of the biogenic amine theory of depression? So basically, it's essentially saying that people are depressed because they don't have enough neurotransmitters in their brain. Therefore, in order for us to treat depression, we should just increase the amount of neurotransmitters in their brain, which works to a point. However, all your antidepressant drugs take about 4 to 6 weeks to work, and that's a big flaw, because theoretically, if all that was changed is the fact that you don't have enough neurotransmitters, then taking that first dose and increasing that amount would help you. However, it's those secondary adaptive changes which occur after having taken the drug for about 4 to 6 weeks that cause your effect. So your most commonly used ones are your SSRIs, which are written here and usually end in "ine." And they block the reuptake of 5-HT. So they require you to release 5-HT, but once it's released, they stop it from being taken back up, and therefore you build it up in the synapse. The more you have there, theoretically, the happier you become. In the initial stages, they actually cause anxiety and suicidal ideation. So in the first couple of weeks of taking an SSRI, the patients are really, really vulnerable. And they can be really shitty because often these patients don't necessarily want to take drugs, and especially due to the stigma of having something like depression. And they take this drug, they become suicidal, and they may follow through. So it's really important to give them really good supports. Sexual dysfunction is really big, so people can become depressed. People can be depressed, they take these drugs which are supposed to make them feel better, then they get sexual dysfunction on top, and that makes them even worse. So sexual dysfunction is probably a really big one. Hyponatremia, have you guys heard of SIADH? So these drugs can cause SIADH. And serotonin syndrome. Have you guys heard of serotonin syndrome? So essentially, if you have too much serotonin, you go into overdrive, you become diaphoretic, you get like diarrhea, and it can have pretty bad consequences. Usually by itself, these drugs aren't going to cause it, but they can cause it when used in conjunction with other drugs that release serotonin. The biggest ones are party drugs, like ecstasy. So if a patient is depressed and they take this kind of medication, they go out on a night out and they take some ecstasy, then they can come in with serotonin syndrome. They can also reduce your seizure threshold, so they can precipitate seizures in individuals who are more likely to get them. When used in higher doses, they can be used for things like OCD. Tricyclic antidepressants, these are less commonly used now because of their really vast side effect profile. And the biggest ones is the anti-SLUD and your cardiac dysrhythmias. So patients who are depressed and who are taking these can use these drugs to overdose themselves. They get a cardiac dysrhythmia, they get QT prolongation, and then they can fall dead. They block a whole heap of different receptors, and therefore that's why they have such a varied side effect profile. Your NSRIs, these are slightly newer and they have less of a scattergun, so it's noradrenaline and 5-HT reuptake. Their biggest side effect is hypertension. Interestingly, yawning is actually really commonly described. So these patients yawn a lot and they can become tachycardic. The hypertension can be quite problematic in these patients. So if it is, they need to be swapped. This you probably don't really need to know much about, besides the fact that Mayer inhibitors can cause the cheese reaction. Have you guys heard of the cheese reaction? Yeah, so intake of tyramine can cause really bad effects. Tetracyclics, once again, you don't really need to know about these ones, but these are good for the elderly because they cause sedation and weight gain. Depression in the elderly can precipitate symptoms such as insomnia and weight loss. So this drug is really good for the elderly. And these ones block your presynaptic alpha-2 receptors. So they stop the autoreceptors from realizing that there's lots of noradrenaline out there, therefore let's stop creating it. This one you don't really need to know. Lithium, this is used in mania, and all it does is it replaces sodium and alters the way that the neurons work and how neurotransmitters are released. It can cause diabetes, nephrogenic diabetes insipidus, and it can alter your thyroid as well, and your thyroid can go up and down, up or down. What's the other drug that can make your thyroid go up or down? What did you say? You want to say it? I think I heard someone say amiodarone. So amiodarone is the other drug that can make your thyroid go up or down. In terms of Alzheimer's, Parkinson's and whatnot, you won't really need to know much about Huntington's. Parkinson's they can ask about, and they can do the same with Alzheimer's. Alzheimer's and Parkinson's, because patients can often get both, it can be a balancing game as to which one you treat. So anticholinesterase inhibitors can be used in Alzheimer's, and they inhibit the breakdown of ACH. So remember that ACH and dopamine are often in direct competition. So if you increase one, you're decreasing the effects of the other. So this is going to cause SLUD type side effects. So usually we talk about anti-SLUD. This is going to cause SLUD. And because it's working in the brain, it can cause vivid dreams and depression. They aren't really that good. So it's a mediocre halt and deterioration. So generally, patients who take this get a 3-month benefit. After 3 months, the benefit is gone. NMDA receptor antagonists probably don't really need to know much about this either. Levodopa and a COMT inhibitor. So this is pretty important. So levodopa can either be coupled with a carbidopa or a benserazide, and it's used in Parkinson's. The COMT inhibitor is purely there to stop the peripheral breakdown of the levodopa. So that works peripherally, allows the levodopa to get up into the CNS, where it is then converted into dopamine and has an action and allows the patients to move again. It's got a limited duration of effectiveness, so you don't give this in patients who get early onset of Parkinson's, because after about 5 years, it stops being effective. The ADRs are purely to do with excessive dopamine. So you have orthostatic hypotension, cardiac dysrhythmias, CNS depression, hallucinations. The big ones are off effects and dyskinesia. So an off effect is can often be where the drug is wearing off and they suddenly they get the Parkinson's symptoms back. And dyskinesias can be too much of anything is a bad thing. So if this patient allows them to move again, if you give them too much, they'll go into moving too much. Right? So they get like the dyskinesias. The difference between a levodopa and a dopamine receptor agonist is the way that they work and are released. So dopamine receptor agonist is going to come into the body and work at all times, right? So it's going to have more of a chance of causing your dyskinesias and things, purely because it's always going to be active. A levodopa is going to get up into your brain, be converted into dopamine, and just sit there ready to be released. So your body will tell when the dopamine should be released. So theoretically, you should get less movement-type side effects from a levodopa compared to your dopamine receptor agonist. This is really good for early onset because it doesn't have the whole duration of time with its effect. Its ADRs are the same because they're both levodopa and D2 receptor agonists at the end of the day are going to act on dopamine receptors. These two you don't really need to know about. Huntington's you don't really need to know about. Any questions? Alright, so antibiotics. So I can't remember if we had questions similar to what the principles of anti-infective therapy is, but you should know about this anyway because it's really quite important. You need to realize that anti-infectives are either going to be time-dependent or concentration-dependent. A time-dependent drug means that it needs to spend a certain amount of time above a certain concentration. So have you guys heard of like the MIC? The minimum inhibitory concentration, yeah? So it needs to spend a certain amount of time above that level for it to be effective at all. These drugs you administer frequently. So any drug that's time dependent, you administer it frequently to keep it above that stage. Because like you know, when you administer a drug, you have that initial spike and then that fall. So you want to hit it again before it falls too low. A concentration dependent drug is one that will, the higher the level is, the better. So these drugs you give usually once a day, but you give them really big, a really big whack of a dose. Time dependent, it doesn't matter how high above that MIC level the concentration is, it's not going to work any better. So these are your time dependent and your concentration dependent. Post-antibiotic effect, these are the drugs where you give it now, and even after it's worn off, it's still going to have an effect on the body. The two biggest things you need to realize is that beta-lactams or penicillins are time dependent, so they're going to be given quite frequently. Then your aminoglycosides, such as like a gentamicin, is concentration dependent. This is the list that's in AMH. So the AMH has a list of all the antibiotics and what bugs they target. Obviously, this is not something that you're going to remember for your exams, but what you should be remembering is each drug, whether it works for gram-positive, gram-negative, or anaerobes, or atypicals. So those are the four categories you should remember. And then you should remember what kinds of bugs cause what kinds of conditions. So, who can tell me a little bit about, is E. coli gram-positive, or gram-negative? Gram-negative. What's it most commonly implicated in? What kind of infection? UTI, yeah. So that's the kind of thing that you need to know. So you need to know that E. coli is a gram-negative bug that's commonly implicated in UTI and is treated with trimethoprim. That's what you need to know. You don't need to remember this list. It would be also good to know which ones inhibit cell wall synthesis and which ones inhibit protein synthesis, because you might be asked about that as well. So generally, all antibiotics have a risk of allergy, as with all drugs, or rash and angioedema. They can also cause a lot of stomach upset. This can come about because they kill the normal flora of the stomach, okay? And they can cause vaginal thrush, once again killing off normal flora, allowing the other bugs to accumulate. Beta-lactams, or your penicillins and cephalosporins, these are your most commonly used. This is one of the ones that inhibits cell wall synthesis. I don't really think you need to know how they do it. I don't think that's a good high-yield use of your time. Once again, you're probably better off memorizing things for other questions. But if you have time, it would be a good idea. So they all cover gram-positives. So you're really, even your really narrow spectrum ones cover gram-positive. What is the most common gram-positive bug? Yeah, staph and strep. Yeah, so those two. And so those are your gram-positive cockeye drugs. All the penicillins are going to cover things like that. They're commonly implicated in skin infections. Then you've got gram-negative cover only in your broad spectrum. What makes something broad spectrum? So do you guys know of a broad spectrum penicillin? So you guys would have heard of like a clavulanic acid. So that's a beta-lactamase inhibitor that can be added to a penicillin, which helps stop bugs that can create a beta-lactamase, which can break down penicillin, stops them from working. So that makes them broad spectrum, and that means they can affect gram-negative bugs as well. There are some bugs. Have you guys heard of ESBLs? So extended spectrum beta-lactamase. So these broad spectrum drugs aren't really good against them. Commonly, beta-lactams are used in respiratory conditions, skin conditions really, really commonly. UTI often as a second line after trimethoprim, and they can be used synergistically with aminoglycosides. Glycopeptides or vancomycin. What's the one bug that vancomycin is really good for? Yeah, I think I heard it. MRSA, or golden staph. This is used really commonly for that. Once again, similar to a beta-lactam, inhibits cell wall synthesis. It's only really used in MRSA or people at risk of getting MRSA. It's quite broad spectrum, so it can cause C. diff. As you guys would know, C. diff mostly occurs in patients who've post-antibiotic use. You've cleared out all of their normal flora, and now the C. diff comes and proliferates. It requires therapeutic drug monitoring, so you need to take levels for these patients, and the dosing really depends on their renal function and their weight. Tetracyclines, so doxycycline, so these inhibit protein production, and they cover your atypical drugs. So often this is prescribed in conjunction with something else. So for a pneumonia, for like a community-acquired pneumonia or hospital-acquired pneumonia, you give them something like benzylpenicillin, which is a penicillin, or a ceftriaxone, which is a cephalosporin, plus a doxycycline to cover your atypical bugs. The other commonly used indication is malaria prophylaxis. They can cause esophagitis, like we talked about with the with like alendronate and risedronate, the bisphosphonates. And they can cause staining of teeth, and they shouldn't be used in pregnant people because it can cause bony deformities of the fetus. What are your atypical bugs? You guys know? So commonly your atypical bugs can be things like Campylobacter, Haemophilus, Moraxella, Pasteurella, Yersinia, Chlamydia, things like that. Macrolides, these aren't commonly used. The biggest use of these ones is in people who have a penicillin allergy. So they cover a good spectrum of bugs, gram-positive and gram-negative, and they are used they work by inhibiting protein synthesis. They can have some interaction with other drugs and can prolong your QT as well. So they might not be good in patients who are on other drugs that can prolong their QT. Aminoglycosides, this is the other one that you might get quizzed about. They have a really big effect on your kidneys and your ears. So if your renal function is down, these aren't a good drug because they're going to hang around for a long time, and they can cause ototoxicity. The ototoxicity and the nephrotoxicity is thought to be dependent on the number of times you administer this drug. So what happens in the hospital is, a lot of hospitals, so like the Royal Melbourne, does not use this drug because they've had patients die from their renal failure. But what happens is you give a really big first dose and you just don't use it again. They're used for really serious gram-negative infections. They're really good at gram-negative cover, but using something like a ceftriaxone actually gives you a very similar cover, and that's why they're not very commonly used. Fluoroquinolones, so these inhibit protein synthesis. So it's really important for you guys to know which one's a cell wall and which one's a protein. As you can see, the cell wall ones, because gram-positive bugs have a cell wall, commonly are used for gram-positive infections. Protein synthesis is commonly used for gram-negative infections. So fluoroquinolones, most commonly ciprofloxacin, is used in UTIs and serious gram-negative infections. They're also really good at getting into bone, so they can be used for things like osteomyelitis. They have lots of side effects, and they're one of the most common causes of C. diff. So you should remember that as well. Metronidazole, really good for anaerobes and protozoals. So patients who've come back from overseas and have like a gastroenteritis, oftentimes you give them a metronidazole or a tinidazole. These inhibit DNA synthesis, so it's kind of a step forward from protein production. Metronidazole is first line for C. diff. That's really important to remember, and they're also used in like a H. pylori type infection. But what you should remember is that they inhibit DNA synthesis, they cover anaerobes, used for anaerobic infections and C. diff. I don't really think you guys need to know the side effects of a lot of these drugs for your exams. Potentially, for some of the ones that I've really emphasized, you might need to know, but for the others, you probably don't. Lincosamides, very infrequently used. Protein synthesis, gram-positives and anaerobes, biggest causative of C. diff. Others you probably don't need to know. Then guanine analog is probably the only antiviral that you need to know, so things like famciclovir and acyclovir. And they inhibit the attachment and the entry of the virus into the cell. And they're used for herpes 1 and 2. Any questions? All right, so you guys should have your cardio physiology down pat because you're going to get a lot of questions on that. You got your A, B, C, D, E. I'm sure everyone's already seen this before, so we'll just go through them quickly. ACEs and ARBs are essentially the same drug, so just remember one set and apply it to both. Your ACE inhibitors are the ones that end in pril, and they prevent the conversion of ACE1 to ACE2, which everyone knows. What you need to know is that they prevent cardiac remodeling, which leads to heart failure. So patients who've had, heart attacks, or patients who are going into heart failure, you give them this drug because it literally prevents the heart from changing its shape. They also prevent microalbuminuria, which is a consequence of diabetes. But also note that these patients, when you first start an ACE inhibitor, their renal function is going to go off. And that can be a little bit off-putting, but in the long run, it actually helps a lot. Cough is the one side effect that you will probably be quizzed about, and everyone already knows ACEs cause cough. If they get a cough, you usually switch them to an ARB. And they're also implicated in the triple whammy. So ARBs, same as before, but they just work slightly differently, where they stop the binding of angiotensin II to its receptor. ARBs actually do cause cough, but once again, it's a Monash thing, where ARBs don't cause cough. But in real life, ARBs cause cough. Beta blockers, so these are the ones that end in lol, and they are really good because they reduce your heart rate, your blood pressure, and your cardiac contractility, which means they can be used in a variety of different things. Reducing your heart rate is good for anyone who's tachycardic, so once again, people with hyperthyroidism. Reducing your blood pressure, obviously good in hypertension. Reducing cardiac contractility, really good in heart failure where your heart is weak. You can have non-selective. What the fuck? So you can have non-selective or beta-selective or beta-1 selective. And I don't think you really need to know them, but just know that they exist. And obviously, the more selective something is, the less side effects it's theoretically going to have. Because you're reducing how much your heart can output, that is the basis of almost all of its side effects. Your heart can't pump out as much as it could before, therefore you're going to be short of breath. Your heart can't pump as hard, therefore your peripheries aren't going to be as well perfused, therefore you're going to have really cold extremities. If your muscles aren't receiving the oxygen that they need, you're going to become tired more quickly. Hypoglycemia often presents itself as a tachycardia and like palpitations, right? By reducing your heart rate, you're going to stop that from occurring. So these drugs can mask hypoglycemia. So beta blockers are not a good first-line drug for diabetics. For diabetics with hypertension, you use ACE inhibitors because an ACE inhibitor is going to stop the renal consequences, or it's going to help to prevent the renal consequences of diabetes, and a beta blocker is just going to mask the problems that diabetes can bring. And obviously causes a bradycardia. You never use a beta blocker with a verapamil or a diltiazem because they have an additive effect and result in heart block. So the heart just stops beating, or it stops beating efficiently. Calcium channel blockers are split into dihydropyridine and non-dihydropyridine. Dihydropyridine act peripherally and work on your peripheral vessels. Non-dihydropyridine work on the heart. So they block L-type calcium channels. They stop calcium from getting in. The less calcium that's in there, the less contraction that can occur. If you're not contracting, you're going to be relaxing. And that's how they work. Because everything is being relaxed and all your vessels are being vasodilated, they're going to cause vasodilatory side effects. So you're going to get flushing. So if you think about it, if the vessels on your face are a lot more vasodilated and a lot closer to the surface, then you're going to become more red. They can cause a headache. So headache is caused by vasodilation, not vasoconstriction. And peripheral edema. So if your vessels become vasodilated, they become more leaky, and you can leak out into your peripheries. The biggest thing is that you can't treat peripheral edema due to a calcium channel blocker with diuretics. Because you don't actually have an excess amount of volume in your body, it's just that the volume is not adequately distributed. These are your less commonly used ones, and you probably don't need to know them. You guys need to know your nephron really well, and you need to know what goes in where, and where the different drugs are used. It's a bit of a pain, and it can be hard to remember, but it's really good to know it. So these are your types of diuretics. Loops and thiazides are your most commonly used, and the other ones aren't really that commonly used. If you're pissing out more frequently, your electrolytes are going to be off because your kidney is involved in your electrolyte balance, and if you're screwing with how the kidney works, then your electrolytes are going to be off. Your most commonly affected are sodium and potassium. They're the two most important ones. You're going to be dehydrated because you're reducing the amount of fluid in your system. Because you're dehydrated, you're going to become dizzy because your blood pressure is going to fall, especially upon standing. Hyperuricemia and gout. So if your uric acid goes up, that's a risk factor for getting gout. That makes sense. And cramps occur as a result of often magnesium being lost. Loop diuretics are your most commonly used diuretics, and they are used for edema. So even though loop diuretics can drop your blood pressure, they're not used for hypertension. They're only used for edema associated with either heart failure or chronic kidney disease, usually. They can affect the amount of water in your ear canal and in your ear system, so they can cause things like tinnitus, vertigo, and deafness, aside from all the other side effects we've already talked about. I'll leave you guys to go through these yourself, but basically what you need to know for each diuretic is where it works. So this works in the loop of Henle, which makes sense because it's a loop diuretic, and it affects the sodium, potassium, and chloride transporter. So it'd be good to have a read of this, but for the purpose of time, I'm not going to do it. Thiazide diuretics, these are used for hypertension and not edema. So you need to make that distinction. These can cause hypoglycemia, so these are not good drugs for diabetics. Although they're first line, as part of the ABCDE, they are not commonly used first line in the real world. So these work in the DCT, and then they act mostly on sodium and chloride. Aldosterone antagonists, they're used sparingly. Spironolactone is used much more frequently than eplerenone, and they are mostly used in refractory edema, where you know that the cause is due to hyperaldosteronism. They can also be really good if the patient has edema, but their potassium is starting to get a little bit off. Use these medications because these don't increase the potassium excretion, so you're not going to get hypokalemia. Spironolactone only, not eplerenone, causes these. So spironolactone is a hormone-like drug, and therefore it's going to cause hormones-like side effects. And they work in the late distal tubule and the collecting ducts, and they work on the NAK ATPase pump. Sodium channel blocker, probably don't need to know much about. And these you probably don't need to know much about. Antiarrhythmics. So you guys should know the action potential and what the different stages of it are. And you guys have heard of the sunblock potassium channels, yeah? So you can just use that as a mnemonic to remember. So your class 1s. Class 1's really difficult because there's no one thing that I can say, oh, they end in pril or whatever. So you just kind of have to remember which ones are which. If it's easier for you, remember the others and just know that all the rest will be class 1. So they reduce the maximum rate of depolarization in phase 0. So that's here. So they slow that down by blocking the sodium channel. So if sodium can't get in as fast, your action potential is going to go for a longer period of time. Most arrhythmias are tachyarrhythmias. The patient has a high heart rate. They infrequently have a bradyarrhythmia. So most of these drugs are used to decrease how quickly the heart contracts. There's 3 different subclasses. So one of them prolongs the refractory and slows the conduction. And I don't really know if you need to know that, but if you can remember it in an easy way, that would be good. And because they don't have they're not one class of drug, their side effects can be greatly varied. But you don't really need to know the side effects of these drugs. One really important thing to know is that anything that can screw with the rhythm of the heart can worsen the arrhythmia. So often these patients are trialed on an antiarrhythmic, and if it doesn't work, they get switched to something else. Class 2 is a lot easier. Beta blockers, we've already talked about them. Same considerations, same everything. They inhibit phase 2 and 4. So that makes it easy to remember in terms of the side effects and considerations. Potassium channel blockers. So amiodarone this is where amiodarone comes in. And they inhibit phases 1 and 3. Amiodarone is one of the drugs similar to methotrexate, which causes a wide variety of side effects. And it's pretty much from top to bottom. That's how I usually think of it. So from top, it's working on your nerves. So you're going to get peripheral neuropathies. Down to your neck, you're going to get thyroid dysfunction. It can make your thyroid go up or down. It can cause taste disturbances. It can screw with your liver and your kidney. Corneal microdeposits, so it screws with your eyes, and they need to have regular eye checks, and also with your lungs. Its half-life is extremely long. It can be up to like 50 days. So when these patients come in and they have an arrhythmia, you give them one dose of this drug, it's not going to do shit. So what you need to do is you need to load them up. So typically they get a loading regimen that goes across 2 to 3 weeks, and they take a large quantity of amiodarone. The other implication of that is, if the patient has really bad side effects on the amiodarone, it's really difficult to treat them because the amiodarone sticks around for so long. Calcium channel blockers, you use your non-dihydropyridines, the ones that act on the heart, because the ones that act in the periphery aren't going to have as much of an effect. And they inhibit your phase 2. Cardiac glycoside. The digoxin helps inhibit your NAK pump. It replaces the potassium on the NAK pump. And by doing that, it renders the sodium-calcium pump inactive. Calcium ends up building up inside the cardiac myocyte. The more calcium you have, the harder a contraction you can form. So this is really good because it helps the heart to pump better. And it's one of the reasons why it's used in heart failure. Hypokalemia is a big issue with this one. Because it replaces it competitively, it acts competitively with potassium on the NAK pump. If you don't have enough potassium, too much digoxin will bind and you'll get an arrhythmia. So hypokalemia can result in digoxin toxicity. Angina is essentially inefficient oxygen to cardiac muscle. So your demand exceeds your supply, and that's often due to atherosclerosis, meaning that not enough oxygen can be delivered. It can be chronic and stable, which is your most common. Once it's chronic and stable, it can progress to an unstable, which is obviously the point right before getting an AMI. So we can either increase the supply of oxygen to the heart, or we can reduce the demand of the heart. So nitrates help us to increase the supply to the heart. They vasodilate, allow for more blood to be pushed through. And by doing so, you relieve that angina feeling. These are used in the imminent stages of angina. When someone has chest pain, you give them a GTN, and that helps to vasodilate everything, and usually their pain goes away. Because it's vasodilating, suddenly you're going to have a big fall in your blood pressure. So these patients are really, really dizzy when they take it. Due to your reflex mechanisms in your body, if your blood pressure falls, your body sees that as a problem and gives you reflex tachycardia. These patients also get really bad headaches. Now, if you've noticed, this is a vasodilator, just like a calcium channel blocker is a vasodilator. So these cause the same side effects. So once again, you can clump these two together. And calcium channel blockers can also be used in angina. So once again, it's a little bit easier to remember. Tolerance can be built to these drugs. So if a patient is taking these on a regular basis, they need to give themselves a nitrate-free period. They can't be used with drugs such as Viagra or PDE5 inhibitors because you get too much vasodilation and you go into hypotensive shock. So calcium channel blockers we've already talked about, and they give you vasodilation, just like the GTN, and they reduce the contractility of the heart. So they both reduce your demand and your supply. They increase your supply and reduce your demand. Beta blockers reduce the demand of the heart, so the heart is physically unable to beat harder because of how the beta blockers work. Therefore, the supply becomes sufficient for the heart. And we've already discussed the ADRs. All right, coagulation. So you need to know your intrinsic and extrinsic pathways of coagulation, and you need to know them well. You need to know which ones. So your intrinsic pathway is to do with your PTT, yeah, and then your extrinsic pathway is to do with your PT blood test. Okay. Heparin is one of the big ones. So it attaches to antithrombin 3 and catalyzes this effect. So without antithrombin 3 there, heparin is not going to do anything. So it affects factors 9 to 12 and 2A. The biggest side effect you need to be worried about is heparin-induced thrombocytopenia syndrome. So oftentimes when you give heparin, your platelets can take a bit of a hit. But if the hit is too large and you become thrombocytopenic, then you're at risk of really bad consequences. Obviously, with all anticoagulants, the biggest ADR that you're looking out for is bleeding, because you're thinning the blood out. Protamine is the antidote for heparin. And it's good to know antidotes for major drugs. So heparin, for heparin it's protamine, for warfarin it's vitamin K. Your low molecular weight heparin, they increase your activation of factor 10A by antithrombin 3. So once again, they require antithrombin 3 to work as well. They affect both the intrinsic and extrinsic pathway, and because their ADRs are the same as heparin. These are used subcutaneously, and because they're used subcutaneously, they last for a lot longer in the body, and they have less of an effect on thrombin and platelets, so they're not really going to cause that hits phenomena. Warfarin, this is your most commonly used one that you hear about in uni. So warfarin prevents the production of vitamin K dependent clotting factors, and the way to remember those is that they're the old school TV channels. So 2, 7, 9, and 10. Bleeding is the biggest side effect of that one. You need to wait for existing clotting factors to degrade before the full effect. And it initially has a prothrombotic effect. So warfarin initially inhibits the antithrombotic factors protein C and S. So in the first few days, you're actually at increased risk of clotting while on warfarin. So oftentimes, these patients will be on what's called bridging clexane. So they'll have, if their indication is strong enough, so for example, they've had a DVT or a PE, you give them bridging clexane because you do not want them to be thrombotic. And then once the warfarin comes into play and it's affecting the body like it should, then you can stop the clexane. For someone who's taking warfarin for something like AF, they're not at imminent risk of anything happening. So you don't really need bridging clexane for these people. You need to monitor their PT, or what we call their INR, International Normalized Ratio, because everyone's dose of warfarin is different. You try to keep the INR between a range of 2 and 3 for most indications, such as AF, or if they've had the DVT. If they've had a mechanical valve put in, the range is a little bit higher, 2.5 to 3.5, but you don't really need to know that. Your new oral anticoagulants. So once you get into clinical next year, everyone loves these, the NOACs. I'm not sure if they'll be in your exams. I don't know how much you guys have been taught about them. It was taught to us kind of in passing, so we didn't really get much on it. But it's not a bad idea to kind of know probably rivaroxaban, apixaban, and dabigatran. You don't really need to know much about it. They're better than warfarin in the sense that they don't need regular monitoring. They're not as good as warfarin in the fact that if you overdose on them, there is no antidote yet. Antiplatelet drugs, the ones that you, aspirin, at low doses, aspirin only, so at 100 milligrams, it prevents the production of thromboxane A2, which would be prothrombotic. Aspirin obviously has the same side effects as any other NSAID, which we've already talked about. And it's only really for low-risk patients. So have you guys heard of CHADS or CHADS-VASc? No? So CHADS is a scoring system for how likely a patient with AF is to get a stroke. So if they're quite low risk, then they go on aspirin. If they're even at slightly higher risk, then they go straight to warfarin or a NOAC. So aspirin's only used in a subset of patients who aren't at that high risk of getting strokes. PDE5 phosphodiesterase inhibitors, don't really need to know. Clopidogrel is the other one you need to know. So they bind to platelet P2Y12 receptor, and they prevent the aggregation. So they prevent the platelets from sticking together. And this occurs for the life of the platelet. This is in contrast to aspirin, which has a 7-day effect. Once again, these are really well-tolerated drugs, and the biggest thing you're worried about is bleeding. So you should know both P2Y12 or ADP receptor antagonists in case someone asks you about it on a question, on a paper. So lipid-lowering drugs. So you need to know the different types of lipids. LDL and VLDL are your bad cholesterol. HDL is your good cholesterol, so you try to increase HDL as much as you can and reduce the others. This is your pathogenesis of a plaque forming, and you should know this because this might be this can be quizzed as well. HMG-CoA reductase inhibitors is the most commonly used drug for this condition, and they prevent the endogenous production of cholesterol by inhibiting the rate-limiting step. So you slow everything down. They reduce hepatocyte cholesterol, and they increase your LDL receptors as well. So the biggest ADRs with this one is rhabdomyolysis, which is rapid breakdown of muscle, and myopathy. They have really good plaque stabilization effects, which means they're used in conditions such as heart attacks and strokes. These plaques can often break off and lodge in places, such as in your heart or in your brain. Therefore, you give almost everyone who's at high risk of these conditions a high-dose statin to help stabilize that plaque and keep it in place, prevent it from breaking off. These are really, really good for LDL and overall cholesterol. This is probably the best drug of the group. Fibrates are really good for high triacyl glycerides. They act at a nuclear level, so they're PPAR alpha agonists. This is in contrast to your thiazolidine diones, which are used in diabetes, and they're PPAR gamma agonists. But they help to convert your triacylglycerides to free fatty acids, which your body can utilize for energy. Bile acid resins, don't need to know. Other drugs, don't really need to know. Alright, so GORD, you guys can go through the physiology. Antacids, this just works quite superficially. It helps to neutralize any of the acid that's in the stomach. Because it's working quite superficially, it's going to have a really short side effect, duration of effect, and the side effects are all going to be like stomach upset related. H2 antagonists is the next step up. These block the histamine receptors from releasing acid secretions. Really well tolerated. That's probably all you need to know. Next step up is your PPIs. These are the ones that are used most frequently, and nowadays pretty much everyone bypasses the first two steps and goes straight onto a PPI because of how well tolerated they are and how well they work. So they irreversibly inhibit the HK-ATPase pump. They work for the duration of the life of the parietal cell. So once you stop taking this medication, you have to wait for new parietal cells to be made before the effect of the acid secretion comes back. It's said that they can cause GI upset and rash, but everyone tolerates it really well. And we've already talked about this. They can increase your fracture risk. This is because calcium requires an acidic environment for it to be absorbed. By stopping the acid being secreted in your stomach, you reduce your calcium absorption. And you can also reduce your vitamin B12 absorption as well. And therefore, that's how it's postulated that these can cause increased fracture risk. Don't need to know about those. Laxatives, it would probably be a good idea just to have a general idea of what time the laxatives work, how long you need to take them before they have an effect, and how they work individually. So bulk forming, they aren't absorbed very well, so they help to create bulk and help it to become a nicer stool which can be passed. Osmotic helps to bring in fluid from your extravascular space, from your extra luminal space into the lumen and helps to hydrate the shit and helps it to pass. Stool softeners soften the stool. And stimulants help to make the bowels move more frequently to help you get it out. The most commonly used laxative is Caloxyl and Senna. Caloxyl is a stool softener and Senna is a stimulant laxative. So it's working in two ways to help you go to the toilet. D2 antagonists, things like domperidone and metoclopramide, they help to increase your gastric emptying. So this is really good in patients who have nausea, because oftentimes you're nauseous because it's a feeling in your stomach. By increasing how quickly your stomach moves, we can move all the contents out and reduce your nausea. These drugs, these are all opiate-like drugs, and these opiate-like drugs, one of the biggest side effects of an opiate is constipation. So we use that in order to produce an antidiarrheal. This you probably don't need to know too much about. We've kind of already gone through this. It might not be a bad idea to know where these drugs work. Once again, this is getting a little bit low yield, but it might not be a bad idea to know that metoclopramide works in the CTZ. The other thing you need to know about these particular drugs is because they're dopamine receptor antagonists, once again, anything that works on dopamine can affect Parkinson's or can produce Parkinson's-like symptoms. So like your antipsychotics, these can cause APSC. These can cause your movement disorders. The movement disorders most commonly seen in females who are of a younger age, under about 22. Ondansetron, the cetrons, the 5-HT3 antagonists, really good for chemotherapy-induced nausea and vomiting or post-operative nausea and vomiting. So these come in wafers, and patients who can't keep anything down, it's really good for them because it means they don't have to swallow anything. Analgesia. Opioids is probably the only thing you really need to know about. They mimic endogenous opioids, which are known as enkephalins in the CNS and PNS. They can target various receptors, and based on what receptor is targeted, they're going to cause different effects. Mu is the one that has a therapeutic effect of pain relief. ADRs are long, but you should probably know them. So decreased gastric motility, that's what causes the diarrhea. Not the diarrhea, the constipation. Dysphoria is a shit feeling, so it's the opposite of euphoria, and that's mediated by kappa. Respiratory depression, this is one of the biggest concerns that you have. If you give patients too much opiates, their respiratory drive is going to be lowered, and it can cause them to go into respiratory distress. Pupil constriction, so this is what they mean by patients who've overdosed on opiates. They have pinpoint pupils. That's due to this effect. And the physical dependence and tolerance is probably nothing that you need to worry about. This we can skip over. Local anesthetics you don't really need to know about. Respiratory drugs, you guys said you were pretty good with it. You guys seem pretty tired. Did you want to stop there? The rest of it you can probably read. I've put the information that you need in the colors. So if you just remember those, you should be fine. Any questions?